Hi, Courtney DiNardo here from MD Anderson in Houston, Texas, and I was asked to speak briefly on mechanism-based therapies to prevent AML relapse. This was a talk I gave at the TCT meeting and just wanted to recap a bit. I think it's just really important that we recognize that treatment for AML is not binary anymore. It's not just 7 and 3 for our younger fit patients and HMA or low-dose cytarabine based for our older patients, but we actually really need to incorporate genomic information to best treat our patients. And so for instance, in younger patients who we're giving intensive chemotherapy to, or fit patients, I should say, if you have core binding factor leukemia, like inversion 16 or 821s, we know how important incorporation of gemtuzumab ozigamycin to intensive chemotherapy is. If you have therapy-related AML or AML with MDS-related changes, we know CPX351 is superior, the liposomal 7 and 3 to the standard 7 and 3. If you have a FLT3 mutation, we know outcomes are improved with the incorporation of a FLT3 inhibitor. Currently, we're using midostaurin. There are several clinical trials under investigation with second-generation FLT3 inhibitors that may improve upon this even further. Whether or not the addition of IDH1 or IDH2 inhibitors will also improve outcomes in the IDH mutated patients receiving intensive chemotherapy is an ongoing clinical trial throughout Europe, and excited to see the results of that. And then for patients who are not transitioning to transplant, maintenance therapies like oral azacitidine have now demonstrated improvement in both relapse-free survival and overall survival. And incorporation of FLT3 inhibitors as maintenance, both after therapy and post-transplant, also showing improvement. The SORMAIN trial with sorafenib in particular is one I highlighted. Gilteritinib looks to be a effective post-transplant maintenance as well. In our older patients, getting lower intensity therapies, kind of the new standard of care, has really become hypomethylating agent with venetoclax therapy. If patients have FLT3 mutations or IDH mutations, that is important information, and we're trying to figure out kind of the best way to kind of either sequence those therapies or safely move them into triplet regimens. It's not really prime time yet. So right now, I think really most people are getting HMA ven, and genomic information is really helpful for us to know who is going to have more durable responses, like patients with IDH2, NPM1, maybe SRSF2 mutations have really kind of durable remissions. Patients with complex cytogenetics, P53 mutations, signaling mutations don't have quite the same durability. And so patients who could be transitioned to transplant is something to absolutely consider in that situation, or even considering kind of effective maintenance type strategies in that setting is something that is definitely an ongoing question. So a lot of information in a minute or two, but just to say that, it's not just one or two different treatment options. We can now optimize our therapy for the benefit of our patients. And hopefully that will continue even more so throughout the future. Thank you.